Chapter 2: The Role of Emotion and the Nature of Therapeutic Relationship. Emotions lend richness to human experience. They also serve adaptive functions shaped by evolution that promote effective response to life's opportunities and challenges. Positive emotions facilitate the pursuit of sustenance, while negative emotions lead us to withdraw from or avoid altogether situations that might harm us. The goal of cognitive therapy is not to suppress or eliminate affect, but rather to ensure the capacity of experience the full range of feelings, both positive and negative, in a manner appropriate to the context and situation. Depression as an evolved adaptation. Depression is best defined as an inability to experience positive affect without similar constraints on the experience of negative affect. How can that possibly be adaptive for the individual? There are several different theories regarding what function depression evolved to serve, and one of the leading ones is analytical rumination, which facilitates thinking carefully about complex social problems. It posits that the anticipation of interpersonal loss or social ostracism leads to experience of sadness. That in turn motivates the individual to search for the cause of his distress, that is causal analysis. This leads in turn to the generation of a solution, that is problem solving, which ultimately leads to resolution of the problem that generated the distress. In engineering terms, this is a closed system in which the recognition of the problem triggers a process that leads to its solution. Evolutionary biologists tried to deconstruct depression to discern its function. They found during a depressed state, energy is directed to the brain in a manner that facilitates rumination. There is the amygdala upregulation, which keeps us focused on the source of our current distress. The hippocampus is activated, increasing access to the energetically expensive working memory. And the prefrontal cortex is engaged, making us resistant to distractions. At the same time, there is downregulation of the nucleus accumbens, making us lose interest in hedonic pursuits, and the hypothalamus, slowing growth and causing us to lose interest in reproduction and physical activity. In essence, depression facilitates rumination, while it makes us anhedonic. As we know, unipolar depression is about 10 times more prevalent than bipolar disorder, is twice as common in women, and its incidence explodes in early adolescence, that is, at the beginning of reproductive age. Reproductive capacity puts more demand on female adolescents than it does on males, since a pregnant or nursing woman cannot gather enough calories to feed herself and her infant. Any threat to the offspring compounds the risk to the propagation of the gene line that serves itself as the engine driving natural selection. In such a scenario, ostracism from the troop would have been tantamount to a death sentence, since the banished individual would likely have starved or been picked off by a predator. In such an ancestral environment, any adaptation that facilitated solving complex problems and therefore prevented ostracism from the troop would have been favored by natural selection. Thus, it seems that depression evolved to help our ancestors think hard about complex social problems. And fittingly, cognitive therapy helps to structure that rumination so that the patient arrives at the solution faster than they might have on their own. Because some people get stuck in the rumination process, especially if they adopt a stable trait theory. Focus on cognition to influence affect and behavior. The goal of cognitive therapy is to help ruminate in a manner that is most productive, while being sensitive to patients' emotional distress, which helps both to build the therapeutic relationship and to identify the beliefs that drive patients' affects. At the same time, encourage the patients to do whatever they did before they got depressed, such as maintaining relationships, work routine and recreation, whether they derive pleasure from doing so or not. And the therapist must be alert to any flickers of amusement and satisfaction in a patient so that to enhance those pleasant emotions. Identification and expression of emotions. There is a saying in cognitive therapy that affect is the royal road to the cognition. Hot cognitions are thoughts that drive affect and are primary focus in therapy. Interestingly, many patients have never learned to distinguish between thoughts and feelings. Make them understand that feelings are subject to experiences such as happy, mad, sad, scared, etc. Whereas thoughts are beliefs that can and should be tested for its validity and functionality. For example, the statement "I feel sad" expresses an internal affective state and can neither be proved or disproved. Whereas saying "I feel inadequate" despite the use of the verb feel expresses a belief about oneself that may or may not be true. And believing one is inadequate may drive affect, that is, it may be a hot cognition. It should be made clear to the client that what is expressing is actually a belief. And rephrase the whole idea. When I think I am inadequate, I feel sad. Some patients are not accustomed to identify their own emotions. Encourage such patients to attend to the changes in bodily sensations that sometimes accompany affective experiences. This often helps them to identify important changes that they have trouble putting into words. This works because affect is evolved to organize a coordinated whole body response to the different challenges that our ancestors faced. There always will be coherence between affect, physiology, cognition, and behavioral impulse. Identify any one component and you can make a reasonable inference regarding the rest. For example, in anxiety and anger, the heart beats faster, respiration rate is increased, and the muscles get tense. And sadness is more often linked to a deficit in arousal mediated by parasympathetic nervous system, so that the stomach feels heavy and the muscles feels fatigued. In cognitive therapy, any feeling is appropriate to express, that is, all feelings are legitimate. Try to provide an accepting and non-judgmental environment, in which the patient can express whatever they are feeling in whatever way suits them the best. But emotional catharsis is not the goal of cognitive therapy, nor does it seek to eliminate effect. Rather, the goal is to understand where that effect is coming from and to make sure that it fits the actual situation. The therapeutic relationship. A meta-analysis of several hundred RCTs comparing different kinds of psychotherapies indicated that non-specific factors account for about half of the variance in outcome with respect to acute response, and specific factors contributing about 1/6. The remaining third could be attributed to spontaneous remissions. In cognitive therapy, the therapeutic relationship develops while the work of the therapy is taking place. Unlike other therapies, in CBT, the therapeutic relationship appears to be more of a consequence of early symptom change brought about by application of helpful strategies and techniques. Desirable characteristics of a therapist. Rogers zeroed in on a triad of warmth, empathy, and genuineness as particularly helpful attributes in therapists. Let's first discuss warmth. Entering therapy can be a scary proposition, and we often call on clients to take chances in the behavioral experiments that they are reluctant to run. Warmth in our interactions can support their trust in the process. Conveying a sense of curiosity in the context of caring seems to be the approach that works best. Empathy. Clients are more likely to disclose their inner experiences when they have the sense that they are being understood. The aim is to understand how the client interprets and feels about a sequence of events. This is more important in a resistant, negativistic, or cynical patient who have likely been let down in the past. Genuineness. Genuine therapists are honest with themselves as well as with their patients. And honest does not mean blunt. Patients may misperceive directness as criticism or rejection. It's a delicate balance between what needs to be said and how you say it. If these are done right, there will be optimal rapport in which the patient will be relaxed, open, and talkative. And most importantly, remember to ask from time to time whether the patient feels comfortable with the working relationship and whether there is anything else we can do to improve it. The therapeutic collaboration. As stated before, the goal is to work together with the clients to determine how their thoughts influence their effects, how well these behaviors correspond to the realities in the situation, and how well their behaviors serve their interests. This process is called collaborative empiricism. The patients provide the raw data, namely their thoughts and feelings, and we guide the patients how to look for coherence among the separate components, that is, their thoughts, feelings, physiology, and behavior, as well as how to draw appropriate conclusion from the data. In essence, the client brings the content and we bring the process. Effect in the therapeutic relationship. The therapeutic relationship generates an effective response in both the patient and the therapist. Explain from the beginning that this can occur and explicitly encourage the patients to express any concern or feedback, positive or negative. Encourage the clients to express a hypothetical concern in the first session just for practice. On the off chance, some actual dissatisfaction might subsequently arise. Do your best to accept criticism gracefully and explore its basis in a non-defensive fashion. And you can also fall back on the same tools you teach the client and look to the ways your own hot cognitions may be contributing to your distress. And when this happens, confront the situation immediately and directly. First, aim to heal any breach, that is, acknowledge that something has gone wrong, apologize, and then examine the relevant cognitions for its cause and validity. On the opposite tangent, the client's feelings might go beyond mere friendliness and warmth. When that happens, make it clear that you are flattered, but that nothing will go further. Of the many other difficulties that may weaken the collaborative nature of the relationship, two are particularly common. First, as therapists, we have to guard against beginning to buy into patients' persistent negative views of themselves and their life situations. And the other challenge being, if the patients first get better and then experience a relapse during treatment. This may lead them to decide that the therapy was ineffective or that they are incurable. Alert the clients early in the treatment that such fluctuations are common. These exacerbations provide a valuable opportunity for the patients to reapply the techniques and skills that they have already learned. Furthermore, they help prepare the client to deal with problems that may come after the treatment is terminated. Summary and conclusion. Depression evolved to facilitate the resolution of complex social problems in our ancestral past. And the goal of cognitive therapy is not to eliminate negative effect and anesthetize the client of all distress, but rather to make sure that it is appropriate to the situation. The emphasis should be on correcting inaccurate beliefs and maladaptive information processing in the service of solving life's complex problems.